I'm Mark Lewis, Director of Gastrointestinal Oncology at Intermountain Health in Utah. I'm speaking from the 2024 ASCO Annual Meeting in Chicago, where we've seen some interesting new data in GI cancers. If you'll allow me, I'd like to go in a craniocaudal fashion. It's my anatomic mnemonic, and I think that's appropriate because our plenary session yesterday actually kicked off with some exciting data in esophageal cancer, specifically esophageal adenocarcinoma. This was the ESOPEC trial, long awaited. It's a phase 3 study looking at perioperative FLOT, a chemo triplet, versus the cross trial, which is neoadjuvant chemoradiation with carboplatin and paclitaxel. Now, the primary endpoint was overall survival, and at first blush, FLOT looked to be the true winner. Some really remarkable milestones in this study. And as I'll mention, I have some reservations about the FLOT arm that I'll raise in just a second, but the investigators are to be commended because in a truly deadly disease, they reported a 5-year overall survival in half of the patients that were receiving FLOT. That is truly commendable and really a milestone in our field. The reason I take a little bit of issue with the trial is I still have some questions about methodology. So it wasn't that long ago at ASCO GI, there was a really heated debate called FLOT or not in this precise setting, but asking the question, do we think that patients with upper GI malignancy are even fit enough to handle a chemo triplet like FLOT? And the reason I bring that up now in 2024 is that, to my surprise, and I think of many others, there was a lower than expected completion rate of the patients in this trial that were receiving the cross regimen. The number of people that were able to complete that in full were about 2/3, which compared to a historical control from a trial schema that first emerged over a decade ago, that used to be over 90% completion. So I found that quite strange. I also think this trial suffers a little bit and unavoidably from the evolution of care that's happened since it was first enrolling. And of course, I refer to adjuvant immunotherapy. So now the real question is there synergy between patients who receive radiation up front and then adjuvant nivolumab as per Checkmate 577. In her plenary discussion, I thought Dr. Karen Goodman did a masterful job. I would encourage you to watch it on virtual meeting, really discussing how can we take all these data and reconcile them for optimal patient outcome. And what she ultimately suggested was that we might actually deploy all 4 modalities in the management of these people. So she proposed a paradigm with PET-adapted upfront induction chemotherapy, then moving to chemoradiation, then moving to surgery, and finally moving to immunotherapy. That is all 4 of the traditional arms of oncology, and I find that really rather remarkable. So watch that space. Great trial, really remarkable survival data, but still I'm not entirely convinced that the cross arm was given its due. Next up, I want to talk about pancreas cancer, something that's near and dear to my heart. It affects about 1 in 4 of my patients, and it remains, unfortunately, a highly lethal disease. I think the top line news from this meeting is that KRAS is druggable. I'm probably showing my age, but when I did my fellowship in 2009 through 2012, I was taught KRAS was sort of the undruggable mutation par excellence. This meeting, we've seen maturing data in regards to targeting KRAS G12C with both sotorasib and adagrasib, and the disease control rates are astounding. 80% and more. Really remarkable. I wouldn't have believed that even a few years ago. And what I'm even more excited about is how do we bring sort of a rising tide that can lift all boats and apply this to other KRAS mutations, and not just KRAS G12D, but all KRAS mutations. And I think that's coming, hopefully, with the pan-RAS inhibitors, because once that happens, if that happens, I'll try not to be irrationally exuberant, that would take the traditional mutation found in almost all pancreas cancers and really make it its own Achilles heel. And I think that could be such a huge leap forward. Another matter, however, that remains unresolved at this meeting is in the neoadjuvant setting with pancreatic ductal adenocarcinoma. There's still equipoise, actually, between neoadjuvant gemcitabine Abraxane and FOLFIRINOX. And I thought that was very well spelled out by some of our Dutch colleagues. Who continue to do great work in a variety of cancers, including colorectal. And that's where I'd like to move next, is colorectal cancer. So, of course, immunotherapy remains a hot topic at all of these conferences. I think there was 3 different aspects of immunotherapy I'd like to highlight at this conference in regards to colon and rectal cancer. First off, Dr. Heinz Josef Lenz presented updated data from Checkmate 8HW, which was looking at nivolumab and ipilimumab versus chemotherapy in the first line for MSI high or mismatch repair deficient colon cancer. And once again, the data, which we've had now for several years at the 2-year PFS mark, are incredibly impressive. 2-year PFS rates for Nivo-Ipi are above 70% and down at around 14% for chemo. What was impressive about this meeting is that Dr. Lenz presented PFS2, so trying to determine the impact, if any, of subsequent therapy. And what was going on here, which I think was ethically responsible by the investigators, was crossover. So about 2/3 of the chemo arm crossed over to any form of IO, and just under a half crossed over to Nivo and Ipi. And these PFS benefits continued with upfront IO. So the way that Dr. Lenz sort of phrased it is you really never get the chance to win back the benefit that you would derive by giving immunotherapy first line to someone that has MSI high or mismatch repair deficient metastatic colon cancer. One thing that's still not settled in my mind, though, is does this really dethrone single agent immunotherapy such as pembrolizumab in Keynote 177? And what I'm really driving at is the ipilimumab. Is the juice worth the squeeze? Is the addition of an anti-CTLA-4 agent worth the toxicity that we know comes along with that mechanism of action? So watch this space. I was also really interested in NeoPrism, which looked at the role of immunotherapy in neoadjuvant downstaging of radiographically high-risk stage 2 or stage 3 colon cancer. And here the investigators really make a strong case that upfront in these potentially resectable cases, not only should we know about mismatch repair deficiency, but we should actually be interrogating further for tumor mutational burden, because they had TMB high patients. In fact, the median TMB was 42 mutations per megabase, with really impressive downstaging using 3 cycles of every 3-week Pembro before surgery. So again, I really think we're in an exciting time where even colon cancer that looks operable up front, we might actually have the opportunity to improve pathologic and clinical complete responses before and after surgery. And then finally, I want to bring up what continues to amaze me. So 2 years ago at ASCO, so ASCO 2022, we heard from Dr. Andrea Sercek in the Memorial Sloan Kettering group about the incredible experience they were having with neoadjuvant, or frankly definitive, dostarlimab in mismatch repair deficient locally advanced rectal cancer. I remember being at the conference and there was simultaneous publication of that abstract in the New York Times because it was so remarkable. 100% clinical complete response. The patients didn't require radiation, they didn't require chemotherapy, and they didn't require surgery for locally advanced rectal cancer, provided there was this vulnerability of mismatch repair deficiency. Now, 2 years later, Dr. Sercek and her group have updated that data with more than 40 patients, and again, 100% clinical complete response, including mature complete responses at over a year in about 20 patients. So again, we are really doing our rectal cancer patients a disservice if we're not checking for mismatch repair deficiency upfront, and especially if we're not talking about them in multidisciplinary conferences. One of the things that absolutely blows my mind about rectal cancer is just how complicated it's becoming. I think it is the standard of care to discuss these cases upfront with radiation oncology, surgical oncology, medical oncology, and pathology. Maybe the overarching message I would take from everything I've said today is the oncologist without the pathologist is blind. It's really a dyad, a partnership that guides optimal medical oncology care. And as much as I love ASCO, I often wish we had more of our pathology colleagues here. And I look forward to taking all the findings from this meeting back to Tumor Board and really having a dynamic dialogue. So with that, I thank you for joining me. This is Mark Lewis speaking for Medscape from the 2024 ASCO Annual Meeting in Chicago. Thank you.